Great. So thank you so much for having me. It's always a joy to do these webinars because we really love to share, the excitement that's going on in the field of multiple myeloma, with patients, most importantly, because you are the ones that are going through it and ultimately would benefit the most from it as we continue to search for a cure for this disease. So today I'll be covering the topic of monoclonal gammopathy of undetermined significance to multiple myeloma. And we'll talk about some of these hot topics at the moment of early therapy for patients that may be at risk of developing multiple myeloma. So we'll review the prevalence of MGUS and smoldering myeloma. We'll talk about some of the tools we now have in the clinic to identify the patients that are at highest risk of progression to multiple myeloma that we find in the precursor state. And then we'll finish by talking about some emerging data for early therapy in high-risk smoldering myeloma. And then this will be followed by a Q&A, which I look forward to seeing some of your questions, and that'll be done in that final portion. So before we start, I just wanted to get everyone on the same page about the terminology that we'll be referring to throughout the presentation. So this disease, these groups of diseases, I should say, are plasma cell disorders that start from the precursor condition called MGUS, or monoclonal gammopathy of undetermined significance, and then goes into smoldering myeloma and then ultimately into multiple myeloma, which is symptomatic and needs therapy. MGUS is defined by having less than 3 grams of the monoclonal protein or M spike in the blood and having less than 10% plasma cells in the bone marrow if you end up having a bone marrow biopsy. And importantly, patients with MGUS do not have any symptoms. They do not have any myeloma defining events. Myeloma defining events are all the way to the right of this slide under the multiple myeloma category, which include these CRAB features, which includes high calcium levels, kidney failure, anemia, or bone lesions. And then in 2014, the definition of multiple myeloma was updated to also account for several other features that really led to imminent development of multiple myeloma in those patients. So that included having more than 60% plasma cells in the bone marrow, a light chain ratio more than 100, and more than one lesion on an MRI. So those patients historically were in this middle category called smoldering myeloma, still asymptomatic, but at the stage a bit higher than MGUS because they had more than 3 grams per deciliter of the M spike or M protein in the blood, more than 500 milligrams of protein in the urine over 24 hours, and then bone marrow plasma cells somewhere between 10 and 60%. And again, these patients do not have symptoms at that time by definition. Now, there are also some rare presentations of MGUS and smoldering myeloma where they may be associated with certain other findings, such as neuropathy or some kidney damage, but not quite meet the criteria for multiple myeloma. And these entities, terms monoclonal gammopathy of clinical significance, are increasingly rare, but we do see a lot of those. So ultimately, again, most patients with MGUS and smoldering myeloma do not have symptoms, but there are some examples where just having a bit of the protein can lead to some of the abnormalities. So this is really a continuum. So, as the tumor burden increases, patients go from that, again, MGUS stage, which is less than 10% plasma cells, to smoldering myeloma when they get above 10%, and then typically above 60% for multiple myeloma. So, finding the patients in these precursor states is usually by chance. Right now, we don't have any screening approved for precursor conditions or plasma cell disorders. So most of the time, patients will end up getting these blood tests because they're presented with some complaint to either their primary care's office or some other specialist who is thinking about multiple myeloma. So they will send off, this SPEP test, and we find patients with MGUS many times through that method. And then if you are diagnosed with MGUS, the risk of progression to multiple myeloma is generally speaking pretty low, about 1% per year, and that's a continuous risk over a patient's lifetime. Smoldering myeloma is a category that is quite heterogeneous. So you have some patients with smoldering myeloma that have low risk of progression and some that have high risk of progression. And I'll go over some of the definitions of our criteria that we use to define low risk and high risk. And then multiple myeloma, as I mentioned, requires treatment. Here is the prevalence of MGUS that was described by Dr. Kyle in this paper now about 20 years ago. So 3% over the age of 50 in the general population, and that number goes up by approximately 1% every decade. It is more common in men compared to female, and it is, over 5% in patients, or people over the age of 70. There are some populations that are at higher risk of having MGUS, and that includes Black Americans or patients of African American descent, and also family members that have a history of a blood cancer. Here is the study called the ISTOP-MM study. This was a study done in Iceland where they actually offered screening to their population over the age of 40. And approximately half of the population of Iceland over the age of 40 enrolled in this study. So this is the largest study we have that gives us the numbers in terms of how common MGUS is. And actually, for the first time, it told us how common smoldering myeloma is. So about 75,000 patients were screened for, this M protein and serum-free light chains, of which a little over 3,000 were positive for MGUS. And that translated to about 4% again of the general population over the age of 40, and it was 5% over the age of 50. And again, over each decade, that number goes up by approximately 1%. So that should tell you that MGUS is not that uncommon. If you go and, again, screen people, over, let's say, even over the age of 80, you may find almost 1 in 10 that will have MGUS. And now we have even more sensitive techniques to identify some of these monoclonal proteins. And with that method, that number may actually even be higher. And then, as I mentioned, for the first time, because of this study, we learned the incidence or prevalence of smoldering myeloma. This is, again, the middle category. And that was about 0.5% of the population over the age of 40. And about a third of those patients actually had intermediate or high risk smoldering myeloma with the risk of progression to multiple myeloma. And then we here in the US have been doing a study called the PROMISE study that's run by my colleague, Dr. Gobriel at Dana-Farber. This is now again looking at screening in a population that's at risk or that we know is at high risk of having these monoclonal gammopathies in the first place. As I mentioned, either Black individuals or folks with a family history of a blood cancer. And as you can see on the left, there is again an increased incidence of having these abnormal proteins in the blood that increases with age. And then in the middle, you can see that patients that are over the age of 50, again, you have a higher risk of MGUS, again, about that, 6-ish% number. And then if you add some of these, more sensitive techniques like mass spectrometry, which is a new way of detecting these proteins, that number is close to 13%. So quite a bit. And then same thing is seen in patients that are of African American descent. The number is actually 17% over the age of 50. So, again, these are more common in certain populations. So here is the risk of progression of both smoldering myeloma and MGUS. So on the bottom, you can see MGUS, as I mentioned, a very steady 1% per year risk of progression. So in 20 years, you got about a 20% chance of developing MGUS. So most people that I see in clinic, they have a very small amount of monoclonal protein. They don't have any symptoms. It was picked up by chance. For the most part, they are typically observed. They're just followed once or twice a year, depending on the degree of abnormality. But they have to be followed over the course of their lifetime because some patients with MGUS will never develop myeloma. Actually, most won't. But it can look very steady for a long period of time and then suddenly start to change. So this is something again that we can't right now look at, 1, 2, or 3 values and say, okay, you're, clear for the rest of your life. This is something that is typically followed for a person's lifetime. And then on the top, you can see smoldering myeloma. So this is a much more heterogeneous population, as I mentioned. You can see about half the people will convert to multiple myeloma in the first 5 years, about 10% per year risk of myeloma. And those that don't will then, have a risk that's a bit closer to MGUS, about 2% per year over the course of their lifetime. And this is, again, a very heterogeneous population that we are now working on identifying who these people are that are in that first category where half will convert to multiple myeloma in the first 5 years. So here were the original risk stratification tools that we had for smoldering myeloma. So the original Mayo Clinic model looked at several different criteria to identify patients, again, at high risk of progression. So if your M protein was more than 3 grams per deciliter, if your bone marrow plasma cells were more than 10%, and then if you had an abnormal serum-free light chain ratio of more than 8, having all three of those category predicted about a 50% chance of developing multiple myeloma in the next 2 years. So that was our original sort of high risk definition for these patients. And that's what we were kind of assessing in the clinic to know who is at risk of progression. And then the Spanish model came around the same time. This looks at slightly different variables, looking at how your other immunoglobulins are. So if those are suppressed, and if your bone marrow plasma cells, look abnormal using these, immunophenotype, then that also predicts about a 50% chance of progression at 2 years. So these were some of the criteria we were using about a decade or so ago to try to identify those truly high-risk patients with smoldering myeloma. But as I mentioned, the definition of smoldering myeloma or definition of multiple myeloma, I should say, changed in 2014 because historically, based on the data I just showed you, some of those patients, were classified as smoldering myeloma, but that changed in 2014 where they were kind of bumped up to multiple myeloma. Again, so if they have more than 60% plasma cells in the marrow, light chain ratio more than 100 or more than one lesion on MRI, we no longer call those patients smoldering myeloma, even though they were asymptomatic. So with that change in definition, we have to kind of rethink what we call high-risk smoldering myeloma compared to, the patients that may have potentially low-risk smoldering myeloma. So what are some of these new criteria? So the one that's most commonly used in the clinic that's actually quite easy to use is this 20-20 criteria. Now we're looking at different cutoffs for where the M proteins are and the light chains are and the bone marrow plasma cells are in patients with smoldering myeloma. So if you have more than 2 grams of the M protein in the blood, if your serum free light chain ratio is more than 20, or if you have more than 20% plasma cells in the bone marrow, having two out of those three characteristics now accounts for, again, that high risk smoldering myeloma category, where approximately half the patients with those abnormalities will develop myeloma at 2 years. Conversely, those that don't, have about a 6% chance of developing, multiple myeloma at that 2 year mark. So it's pretty helpful in identifying, again, these patients that may be at high risk of progression in the next couple of years. But what that model fails to account for is, the biology of these cells, right? So we're basically talking about how much of the disease is present and sort of using that to identify, again, people at high risk, but we're not looking into the cells to know whether those are truly high risk cells or non-high risk cells. And there's been numerous efforts, many of those I don't have time to cover in this presentation today, but ultimately we're looking at genomic markers, other markers in the cells to, again, identify the high-risk patients. But the ones that we use in multiple myeloma quite regularly are FISH results. And FISH are just a way of assessing for certain mutations within these abnormal plasma cells. And now this IMWG risk score incorporated these FISH abnormalities that you can see on the bottom of this slide and added this to that 20-20 risk. So again, fine-tuning the patients that may be at more risk of progression. So this calculator will give you a risk score in incorporating your FISH results and can give you an even better prediction of which patients may be at risk of progression in the next 2 years. So if you have a score more than 12 on this calculator, that's almost 3/4 of those patients will develop multiple myeloma. So we're getting better and better at identifying these patients. And one thing we've been working on at our center is this Pangea model, because patients always ask, my numbers were X or Y, 1 year ago, 2 years ago, 3 years ago, but has my risk changed? Whether they've moved or not, whether they've increased. So these dynamic changes are really critical because they can be really important in identifying whether something is changing or not and whether patients would be now more at risk. And even if they don't meet kind of the traditional high risk criteria based on some of these models that I just described, maybe that change in trajectory is more important. So a new updated Pangea calculator 2.0 is now incorporating some of these dynamic changes, whether it be your hemoglobin, your creatinine, rise in the light chains, M protein, etc. So that is becoming a useful tool that, again, we're getting, again, better and better at identifying the patients at risk of progression, at least in the next couple of years from that time point. So whatever criteria we use, the risk of progression using some of these at 5 years is close to 85%, with these models. So, there's a lot of debate about which one of these is better, which one we should be using. Any one of these actually do a pretty good job at identifying the patients that may be at risk of progression. So what do we do now, right? We have the patients identified that we think are, potentially going to develop the end organ damage, such as kidney failure, bone lesions, anemia, high calcium levels, but they're sitting in our clinics and they're basically saying, are we just going to wait for that, right? Are we going to wait until something happens before we, offer them treatment? And as of right now, we don't have anything approved for smoldering myeloma, which I'll talk about in a second, that may be changing. But ultimately, we have a lot of things approved for multiple myeloma, as you can see on this slide. So we've gone from having not a whole lot to a lot, all in the last, especially in the last 20 or so years. So prior to the, mid 90s, we had high dose steroids, some old chemotherapy regimens that didn't work so well. And as a result, the survival for myeloma patients was not that great. On average, it was around 3 years or so, back in the 80s or so. Then came stem cell transplants, autologous transplant that utilizes high dose chemotherapy. That really improved survival for patients and became standard of care for those that could tolerate it. And then there was basically an explosion of, new drugs for multiple myeloma, starting with thalidomide and then then moving on to lenalidomide, which is Revlimid, bortezomib, which is Velcade, and then those combinations really became our standard frontline therapy for myeloma. And these are not old chemotherapy drugs, so their side effect profile is generally speaking, very different and more tolerable. And we were then able to, really treat patients with these therapies many times until it stopped working, and suddenly the prognosis for patients started to improve. And then in the mid 2010, so like 2015 or so, we started getting approvals of the next generation versions of some of these proteasome inhibitors and IMiD drugs, such as pomalidomide, carfilzomib. And then came our first monoclonal antibodies that were approved for multiple myeloma in 2015, daratumumab and elotuzumab. And for those of you that are familiar with daratumumab, it has become, really integrated into our myeloma therapies now, starting in the relapse setting and now essentially universally given to patients at diagnosis because of the efficacy that we see when we've added this drug to our standard combinations of bortezomib and lenalidomide and dexamethasone, where that has become our go-to frontline regimen. And with that, some of the frontline myeloma trials can now lead to really, really high response rates, high rates of MRD negativity, which is really the goal that we now try to achieve. And as a result, have really good prognoses in many circumstances where the disease may stay away in some patients for maybe even close to a decade with that approach. And then, invariably the disease will relapse. And then we have newer therapies now that are in the T cell realm. So we now have two available CAR T cell therapies, which are using your own T cells to attack myeloma, and then three bispecific antibodies, which are again using the T cell mechanism, but these are more like injections. So they're kind of doing what the CAR T cells do, just in a slightly different mechanism, and can be utilized sometimes after CAR T cells. So a lot has changed, and many of these therapies started in the heavily pretreated relapse setting where patients had more than 4 lines of therapy. And now CAR T cells, for example, are approved for patients that have just had one relapse. So we're using a ton more CAR T cells. These are one-time therapies, and ultimately, we're seeing quite impressive results. And just at ASCO a couple of weeks ago, we saw that, there was quite a lot of durability with cilta-cel, one of the CAR T cell products, where approximately a third of patients on the original trial that led to the approval of that product still haven't relapsed, which is not something we have seen before. So there's a lot of excitement with these products. But despite all this, again, maybe that's changing now with some of the data from a few weeks ago. We really haven't quite figured out a cure yet, although the prognosis is improved for vast majority of patients. So the question then naturally becomes, can any of these therapies cure myeloma? And if so, are we using them maybe too late? Maybe we're using them when the disease is not quite, curable. Perhaps using them when you find some of these patients in the earlier disease states can lead to cure. And this has been a big area of research, particularly in this precursor high-risk smoldering myeloma space. So going over the guidelines currently from the NCCN for smoldering myeloma, if you're low risk, you go on observation every 3 to 6 months, or participation in a clinical trial is always recommended, because that's how we learn how to, best move the field forward and hopefully help many, many people like you. And then if you're high risk smoldering myeloma using any of the criteria that I mentioned before, again, clinical trials recommended, or observation is standard of care every 3 or 6 months. And then lenalidomide or Revlimid in select patients, per the NCCN guidelines. And then really only at the time of progression to active myeloma, using some of the criteria, myeloma therapy will then be administered, which is again using those 4 drug regimens and maybe stem cell transplants and now maybe even CAR T cell therapy. So that's really reserved for patients, that actually develop, symptomatic myeloma. So why lenalidomide as part of those NCCN guidelines? Well, that's because of these 2 studies that looked at lenalidomide in patients with high-risk smoldering myeloma. The first one was the Spanish trial that was that was published around 2013, looking at 2 years of lenalidomide and dexamethasone versus observation. The second study was just looking at lenalidomide single agent versus observation. And the second study, the ECOG trial, the lenalidomide was continued until progression. So in the first Spanish study, there was a benefit with lenalidomide and dexamethasone, as you can see on the left, in patients that were treated. And this, again, quite a lot of benefit, both in progression-free and also overall survival. But there's a lot of, kind of critiques of that study now, decade plus later, because this was pre-definition of myeloma changing. So people have wondered whether, some of these people would have met myeloma criteria, and maybe that's why the benefit was so striking. And also at that time, we weren't really doing PET scans and MRIs to identify patients with myeloma and bone lesions. So again, there's some thought whether, again, some myeloma patients were on that trial, hence maybe that's why the benefit was seen. But this was also confirmed in the subsequent trial in a more modern era of this ECOG study where, again, you saw this benefit, but the benefit was really pronounced in patients with high risk smoldering myeloma using the 2220 criteria that I mentioned. There was no overall survival benefit seen in this study, but follow-up needs to be a bit longer there. And there was a fairly high discontinuation rate of Revlimid. For those that are familiar with Revlimid, we know it can have some toxicities. For some people, it can be a bit tough to stay on that indefinitely. But both of these trials really set the stage for maybe early therapy in these patients is the way to go. However, despite these two positive trials and it making it into the NCCN guidelines, it never really, gained widespread adoption. And there was many reasons for this. These trials were designed and conducted at a time where Revlimid was new. This was therapy we were giving to patients with newly diagnosed myeloma. And then we very quickly, as I just mentioned, went from 2 drugs to 3 drugs to 4 drugs. So this data was always a bit, lagging in smoldering myeloma. And that's for many reasons. One is, again, patients are found by chance. We know what the incidence of multiple myeloma is, about 35,000, patients diagnosed per year in the US, and, they come in symptoms. So you diagnose them, and then many times they go on clinical trials and we get a lot of robust data. But for these other precursor conditions, the trials lag because patients, again, are asymptomatic. They're found by chance. And many patients, sometimes don't participate in these studies because they don't yet know, what the right thing to do is. But those that do, again, in some ways help move the field forward based on some of these studies. But I would say what's generated a lot of buzz over the last 6 months or so is this Aquila trial, which is a phase 3 study of daratumumab versus active monitoring in patients with high-risk smoldering myeloma. This used the high-risk smoldering myeloma definition that was the older definition to kind of include the original Mayo and Spanish criterias, and it did mandate patients having advanced imaging, either a PET-CT or MRI during screening to exclude patients that may have multiple myeloma. And patients were randomized to 3 years of daratumumab as a single agent or active monitoring. And patients were followed quite robustly. They had, yearly imaging, bone marrows every 2 years, labs every 3 months. If you were on active monitoring. So really, the active monitoring arm was basically what we aim to do for everybody that's not on therapy. And then patients were followed for the primary endpoint of progression-free survival. And here were the results. So daratumumab significantly improved progression-free survival. So patients that were on active monitoring, the median progression-free survival in this, was about 41 months. So a little over 3.5 years, patients, on average develop multiple myeloma. And at the 5-year mark, 40% of patients, were progression-free, whereas there were 63% of patients were progression-free in the daratumumab arm. And you can see on the right sort of what those events were. Some patients developed CRAB criteria, which are, again, the anemia, the bone disease. Some patients develop SLIM criteria, which, again, is that pre-myeloma or almost symptomatic myeloma category. So really, again, highlighting that daratumumab, led to quite a benefit in this patient population. And I think what really created a lot of buzz was the fact that, it actually improved overall survival. So, overall survival is becoming increasingly harder to show or prove in patients with multiple myeloma now because therapies are very effective. And then, many times the survival is getting longer and longer. So to measure it that far out, based on the impact of the first line therapy is becoming increasingly difficult. Hence, we have other endpoints now that we look at, such as response rates, MRD negativity, things like that. But in this study, you see the benefit in terms of daratumumab improving overall survival. So as a result, this went to the FDA. It's under FDA review currently. It was at the ODAC meeting a couple of weeks ago where actually it was voted in favor of approval. So we'll see what happens, but this may become our first agent approved for patients with high-risk smoldering myeloma. So where do we go from here, right? So, I mean, as I just mentioned, we now have good criteria to identify patients at risk of progression. Observation remains the gold standard. We have, good data with lenalidomide. The daratumumab study may lead to our first approval. All of that is fantastic. But, the question then is, what about the combinations that we give to myeloma patients? What about these immune therapies? Are they going to be even better than giving some of these therapies, on their own? And the big rationale for that is, all the myeloma studies show that if you have a deeper response, if you're MRD negative, you do much better. So is that also true for patients with high-risk smoldering myeloma? Because the complete response rates with daratumumab are less than 10%. So, we're not really even expecting those deep MRD negative responses that we now do with myeloma patients, because by itself, daratumumab is not potent enough to lead to that kind of a response. But despite that, we saw quite a lot of benefit already. So what if we gave them some myeloma-like therapies? So let's go over some of the data of some of those therapies and what they've shown so far. So one of the trials, another Spanish study, was looking at essentially a myeloma type treatment regimen and giving them to patients with high-risk smoldering myeloma. So about 90 patients were enrolled in this study, and they received induction therapy with a triplet regimen of carfilzomib, lenalidomide, dexamethasone. And this was followed by an autologous stem cell transplant. So they got transplanted with high-risk smoldering myeloma, and then they were given maintenance therapy with lenalidomide. And this treatment course was pretty typical of what we were doing for myeloma, maybe 5 or 6 years ago. Now we moved on to more four-drug induction regimens, but this was, relatively new in terms of the approach. And the response rates were very high. The complete response rates were very high, but one of the endpoints was looking at MRD negativity 4 years after transplant, trying to see, can this be curative? And MRD negative rates were, about 60% after transplant, but you can see them kind of dipping as time goes on. So it's about 31% at 4 years. So, 70% or so of patients, were still MRD positive, suggesting that this is not curative in vast majority of patients, but, overall effective and certainly have prevented myeloma in patients that were at risk of myeloma. And about a third of patients in this study, I should highlight, kind of met the SLIM criteria for multiple myeloma. So again, this is again a heterogeneous population with some high-risk smoldering myeloma patients and some active myeloma patients. The next study looked at KRD, again, the same regimen as per the trial I just mentioned, but without stem cell transplant. And this was given for 8 cycles, followed by, again, Revlimid maintenance for 2 years. Very similarly, you saw very high response rates, 70% of patients achieving MRD negative CRs, but you can see the durability of that MRD, over time dissipate. And then if you look at both of these studies, you can see, again, this whole point of, MRD negativity, does that matter in smoldering myeloma? And if you look at the trials and those that did achieve MRD negativity versus those that didn't, we're starting to see very similar curves that we do in multiple myeloma, where ultimately you'll have, better outcomes for patients that do have that deeper response, versus those that don't. So again, sort of setting the stage of what we are already seeing in patients with multiple myeloma. And then we did a triplet study of ixazomib, lenalidomide, dexamethasone. This is an all-oral regimen. So the intent of this was to give a newer combination. At that time, this was done in 2016, and then make it, more tolerable perhaps, because, it's all oral therapies and you don't have stem cell transplant or any of these other approaches, mixed in here. And it was a 2-year treatment program. So you can again see the same thing, people that had a VGPR, a sustained CR, and the handful of patients that got MRD negativity on this study did much better than those that didn't. So really highlighting that response, matters perhaps also in patients with high-risk smoldering myeloma. And there's now ongoing phase 3 trials in this space. So we're now looking at our monoclonal antibody combination. So isatuximab, which is a CD38 monoclonal antibody, very similar to daratumumab. And both of these approaches are being combined with lenalidomide and dexamethasone. And then this is, compared with the lenalidomide and dexamethasone doublet. So, kind of the original studies that showed benefit in high-risk smoldering myeloma is the control arm for these two studies, and then the treatment or the intervention arm adds the monoclonal antibody. So this will tell us a lot. These are phase 3 studies. It'll tell us whether, getting the higher depth of response will lead to better outcomes. I suspect it will, but again, we have to wait and see, what this trial shows. And you always have to kind of balance this out with toxicities with adding the additional agents to patients with high-risk smoldering myeloma. So stay tuned for these results of the next batch of phase 3 trials that we'll get results from in this high-risk smoldering myeloma space. What about quadruplets? So again, as I mentioned, this is the way we treat myeloma currently, when patients come in. So this trial, the ASCENT trial, looked at daratumumab, carfilzomib, lenalidomide, dexamethasone regimen, so DARA KRD. So the trials I just went over were KRD. This just adds the daratumumab to it. And again, high response rates, high MRD negativity rates. This was updated now 3 years ago. And overall, the results looked preliminarily pretty good at that time. And we look forward to follow-up of this study. We have been doing a study of daratumumab, bortezomib, lenalidomide, dexamethasone, or DARA-RVD, again, a very commonly used frontline regimen for multiple myeloma. And the intent of this study has been to see if, giving this quadruplet leads to high rates of MRD negativity. And this trial has a design that's based on MRD. So patients that are MRD negative after those 2 years come off study. Those that are positive, we're then randomizing them to either receive, 2 more years of daratumumab and Revlimid or come to observation, so we can truly learn what happens to those MRD positive patients if you treat them versus not treat them. So we just completed accrual to this study, so we'll be putting our data out, updated data out soon, but we did share some preliminary data at our ASH meeting last year. Again, response rate looks good. The complete response rate's over 60%. Very few people have, developed any kind of progression in terms of biochemical progression. And MRD negativity rate so far looks to be about 65% at 2 years, which is in line with what we expect to see, with this kind of a regimen. And we'll see, what the long-term outcomes are of patients with these quadruplet based approaches. But as I mentioned before, we're now in this era of immunotherapy. We have so many new T cell engagers. We have two CAR T cell therapies. So an immune system is much healthier in patients with smoldering myeloma than it is in patients with relapse myeloma. So giving these therapies early, maybe even better than giving some of the combinations. So, and maybe then some of those combinations can be saved for later for patients that truly need them. And we will try to give these at a very sort of fixed duration, so that way we can limit the toxicities and not lead to any resistance down the line. So as a result, there's several ongoing immunotherapy trials going on in high-risk smoldering myeloma. We've done a few that I'll cover shortly, but there are several being done at other centers looking at some of these, bispecific antibody in combinations or at single agents, and then also a trial of CAR T cell therapy that I'll talk about shortly. So the first trial that we did was the ImmunoPrism study. This was a phase 2 study looking at a combination of lenalidomide and dexamethasone and comparing it to teclistamab, which is a BCMA bispecific antibody that's currently approved for patients with relapsed myeloma. We started this study since it was its first of its kind in this high-risk smoldering myeloma population by doing a safety run-in first to make sure it was safe, and it was. And then we would randomize patients to either teclistamab or lenalidomide and dexamethasone. We modified the schedule of the bispecific antibody to make it less frequent, again, fixed duration, and just to allow for better tolerability. And we were just looking to see whether this worked better than the kind of the response rates, et cetera, that we saw with lenalidomide and dexamethasone. We shared our data a couple of years ago at that time of the first 12 patients that received teclistamab, and we were very impressed by the data. All the patients responded to therapy, nobody progressed on treatment, and our MRD negative rate was 100%, which we had never seen before with these agents as a single agent. Again, perhaps highlighting the fact that treating the people early, instead of later, maybe is more efficacious. These bispecific antibodies do carry a risk of infection and other toxicities, so it's something we've been monitoring obviously very closely on this study. I will say so far we haven't seen the same infectious signal that we do in patients with relapsed myeloma, particularly of those that are high-grade infections requiring hospitalizations, things like that. But again, we'll update the trial soon as it completes its accrual. And CRS, cytokine release syndrome, which is what we see with T cell therapies, was seen in about 58% of patients at this time. But none of the patients developed grade 3 or greater CRS. And as a whole, this has been, from that perspective, very well tolerated. And then we have been doing a study of CAR T cells in patients with high-risk smoldering myeloma. We presented our safety run-in data of the first 6 patients that received cilta-cel in this high-risk smoldering myeloma population. And again, demonstrated that patients got CRS, but nobody got grade 3 or greater CRS. We had some toxicities, as you would expect in patients that received CAR T cells, but those have all been transient. And then again, we saw this same signal of universal response rates and complete response rates and MRD negativity in everybody. And the first batch of patients that received the CAR T cells are now out a year plus, and they still haven't developed disease progression, but we need to follow these patients, way longer than a year to truly know whether this was potentially curative, for those patients that received, this type of therapy. And we've been studying different doses of CAR T cells here, maybe trying to balance out that safety and efficacy signal. So we'll report the results of this as we complete accrual, and this will be the first study that looked at giving CAR T cells in this population in a way or in an attempt to cure the disease before it even happens for these patients. So in summary, early therapy in high-risk smoldering myeloma does show benefit. We have now 3 randomized phase 3 trials that show benefit compared to just observation. And daratumumab may be our first agent approved for smoldering myeloma, which I think is very exciting. But I think the story continues. So we now have the triplet and the quadruplet combination therapy trials in this space. Preliminarily in the phase 2 studies, they show high response rates, high MRD negativity rates, but again, we need longer follow-up to determine the durability of how these MRD negative responses are. And then we have to await the data from these phase 3 trials of triplets versus doublets, to truly see what the long-term outcome looks like when you compare it to, a less intense therapy that are just with the with the doublet combinations. I think we're seeing that the depth of response does correlate with rates of biochemical and slim crab progression. So again, same thing we see in patients with multiple myeloma. And those that do develop some progression of disease after these smoldering myeloma therapies, that space is still a bit unclear what or how we should be thinking about management of those patients. So we've had some patients go on studies, and then if they develop, disease recurrence, it's still asymptomatic, they're kind of back in the same mode, depending on how their numbers look, whether they participate in another study or some other therapy. And then these T cell therapies, again, we're already seeing them, really take over management of myeloma. In the relapse setting, they're being studied in the frontline setting, and they show pretty good efficacy here in smoldering myeloma. So, maybe that's a preview of what we're going to see in patients with multiple myeloma, but ultimately these therapies, show quite a lot of activity. And now we just have to balance out the safety component of this because any therapy has side effects. And again, if we can kind of really thread that needle where we give therapy for a short duration, limit the toxicities, and potentially cure the disease for these patients, then that would be, really amazing. So, we see many patients in our clinic that are very nervous about having this kind of brewing in the background. And ultimately, if we can find something that's going to be as safe as possible and can be curative, I think would help a lot of people. So those were all my slides. We have a great group of team. I always like to highlight that at our center at Dana-Farber, we have the Center for Early Detection and Interception, which is really focused on precursor blood cancers, whether it be precursor plasma cell disorders, leukemia, lymphoma, et cetera. So, we see a lot of patients and counsel them in which approach may be best for them. So kudos to them for helping us with all the work that we're doing here. And that was all my slides, and look forward to answering some of your questions.
Okay, thank you so much, Dr. Nadeem. I know it was wonderful to hear about where we've been, where we're going, and kind of how that's all going to play out. So thank you so much. All right, so we do have time for questions and answers right now. So if you do have any questions for Dr. Nadeem, feel free to drop those in the Q&A. Again, that's going to be at the bottom of your screen. Just tap on that Q&A icon. If you're on a tablet or mobile device, you'll need to tap on the three dots or just tap the screen and then Q&A. While we wait for a few of those to come in, I just wanted to talk a little bit about what we were talking about earlier when we were asking about patients who may be looking forward to these treatments versus those that are maybe a little bit more hesitant. What are you seeing in your practice?
Yeah, I think it's very different in different individuals, right? So I have patients that are meeting some of these high risk criteria, but they understand that their risk of progression may be there, but they also realize that perhaps some of them will not develop myeloma. And in that case, they're willing to wait, right? They're willing to wait to see until, as long as you watch them very closely. Majority of the time, we are able to intervene in time, but there are some patients that you saw in the Aquila trial, even in the active monitoring phase, there were people that were developing, some of these myeloma events. So ultimately, we try to follow those patients very closely and really intervene at the time of treatment when it's absolutely necessary. Conversely, we have some patients that are very young. They're diagnosed in their 40s. They have high-risk smoldering myeloma. They have a busy life. They have young kids, and they are not necessarily thinking 1 to 2 years from, developing myeloma. They're thinking decades, right? So when you're thinking decades, their thought process is very different many times, because they're looking at those, graphs and curves and saying, okay, well, looks like I have a lifetime risk of developing multiple myeloma based on those odds. And with all the therapies that we have coming up for myeloma, they're willing to, after reviewing some of the data, preliminary data that we have with some of these trials, et cetera, they're willing to be treated, right? Because they want to just prevent at least an immediate sort of a risk of developing myeloma and then hopefully a lifetime risk of developing myeloma. So, we see this whole spectrum. And this is why I think it's so critical to kind of get input because, there's a lot going on in this space, as you can see. Even with our first approval of daratumumab, I think we have to see who that is the best for, right? Because there are some patients we see with smoldering myeloma that are almost multiple myeloma. They may have 50, 55% involvement of their bone marrow. They have M proteins that are rising. Sure, they may not have bone lesions or kidney failure or anemia quite yet, but we know it's right around the corner. And I would argue giving them just daratumumab, because that's not what we would do if they were just over the threshold for multiple myeloma, may not be enough, right? Conversely, you have patients that have maybe 10, 12% plasma cells in the marrow. It's been maybe very stable for a couple of years. in that case, they may not need the whole kind of, four drug regimen. So it's so mixed in terms of this population, which is why it's really individualized in terms of this decision making, both from a patient perspective in terms of what they want to do, but also based on their risk profile.
I love it. I love the idea of just a more personalized approach. So that's wonderful. And getting the ability to offer these therapies earlier, you know, as you see the patients developing or seeing how their labs play out. I think that's really important to be able to have that conversation with the patient and have those options available. So that's wonderful. All right, we've got a couple of questions that have come in. First one says, with the immunoprism study, have any patients progressed yet, even after stopping teclistamab?
Yeah, so we don't have like the updated results right now to share. We're just actually finishing up the accrual for the study, actually very imminently. So after that's done, we'll be able to kind of analyze all the data, and share with you. But ultimately, I can share with you that we've had patients that have stopped therapy because they're done with their treatment, et cetera, and they're on monitoring, and people seem to be doing overall, pretty well. So, but we should be able to get you kind of the final update as we get some more longer follow-up. I would say sometime in the next year or so.
Beautiful. Thank you so much. Next question just says, at what point in low risk smoldering myeloma would you recommend a clinical trial?
Yeah, that's a great question because again, the definition of low risk is, depending on which criteria you use, et cetera. So I would definitely suggest, monitoring initially because you have to kind of see if your proteins are rising or not. As I said before, that can really, we may think you're low risk, but actually maybe high risk, right? If you have this like evolving pattern. So it's always good to establish that in the beginning, kind of where you're falling. And then, again, it just depends on what's available, number one, right? So we are looking at not just therapies, we're looking at lifestyle interventions in some of our studies. We're looking at, different dietary and exercise programs to see if that makes a difference. There's plant-based diets that are being studied. There's, intermittent fasting we studied. We did a trial of metformin that, we finished that we will report out. So these things are all, kind of low intensity therapies with a different kind of mindset. So I think those are always great because for the most part, the risk is pretty low and you may get other benefits out of it, right? In terms of, some of the programs that are being designed. So I would always encourage those. In terms of like the actual therapies, we're starting to look at a few different approaches. And again, that just really depends on, to some extent, your risk tolerance of taking on some of these therapies and your kind of big picture view, right? So, this is where I see that really striking difference in some people where, some people are looking at kind of like 40 years from now, and some people are looking at maybe 10, 15 years from now. And it's a very different mindset for those people, depending on how old you are and where you are in life. So I would say it's always good to at least hear about what's out there because I think that really gives you a good sort of sense. And that could be at any of the centers that do, multiple myeloma clinical trials.
Absolutely. And I'm going to do a quick plug here for the Nutrivention 2 study that is currently available. So I will put that in the follow-up email and try to get a link in the chat as well. This is open for smoldering myeloma patients, and they did open it up for MGUS patients as well, looking at different supplements and how that can affect your gut microbiome. So if you're interested in that, make sure you reach out and we can get you guys in touch with our patient navigators. I'm also going to just launch a poll since we talked about clinical trials, just to get kind of a feel from the audience about how they look at clinical trials, given, being this precursor space. So if you want to interact there, feel free. Our next question comes in and it says, are bispecific antibodies and CAR T similar in mechanism and effect? Could you talk through kind of what those look like?
Yeah, that's a very common question, not just in smoldering myeloma, but just in myeloma in general. So they're similar in a sense that they use T cells to attack multiple myeloma cells, and actually similar in a sense many times that they attack using the same target that we use in multiple myeloma called BCMA. So this is expressed on plasma cells, and they go after the same thing. There's other targets that we have, such as GPRC5D, which is also, we have a bispecific approved against that, and there's some CAR T cells being studied against that. So, but these therapies are all taking your T cells towards one of those targets, right? So those are the similarities. The differences are that CAR T cell is an infusion of your own T cells back into you. So they first get collected, they get genetically modified to recognize one of those antigens on the myeloma cells. Then they get expanded and then inserted into your body, where they have you have further expansion, when they get inserted. And it's like unleashing an army of your immune system, against myeloma. So the CAR T cells are a one-time therapy as a result. They go in, they do their thing, then they typically clear the blood and clear the body. And then because of how potent they are, they can just really put the disease in this dormant state, sometimes for many, many years in patients with multiple myeloma, right? So that's the CAR T cells part. The bispecific antibodies are, again, very similar, except they're off the shelf. So they're injections. So typically they'll just be, therapies you get as we've seen some of the other therapies over the years for multiple myeloma. You'll get them initially once a week, then you may get them every 2 weeks, maybe once a month, depending on which product and where you are in your disease. But at least as of now, they are continued until they stop working, although we're studying whether we can, do a more defined therapy even with the bispecific antibodies. But they, again, the mechanism is when you get those injections, one end latches onto the T cells, one end latches onto the, myeloma cell, and it just, activates your T cells to attack the myeloma cell. But there's no T cell infusion, and it's continuous therapy. As a whole, I will say in relapse myeloma, the effectiveness of bispecific antibodies is a little bit lower than we see with the CAR T cells, at least some of the CAR T cell products. But people that respond can actually respond for a long, long time. And, this is going to be a pretty evolving space. Right now, I think for most of us, we think about CAR T cells first, then bispecific antibodies for people that are eligible for CAR T cells in relapse myeloma. There's several reasons for that. One is, because it's a one-time infusions, patients can have a break off therapy, sometimes for many years. And they don't typically develop this T cell exhaustion phenomenon where, because they're not getting continuous therapy. So by the time they develop disease progression after CAR T cells, their T cells will be pretty good to react to the bispecifics. And then you kind of get almost like twice therapy. Doing it conversely, it's a little bit harder because you get continuous therapy with the T cell therapies, and then you collect your T cells. They may not be as good of a quality, and then when you get them inserted, the T cells may not just have that same punch as they would have prior to the bispecifics. But this may change. There's newly diagnosed trials of bispecifics ongoing, and they're certainly a lot easier. You can just get them and start therapy. There's no manufacturing, there's no collection and things like that. So it's interesting to see where this will all fall in the precursor space so far, since we're actually the only center that has, done both of these in these patients so far. They both seem great. So they're just a different approach, and we'll see how long the durability of the response will be.
I love it. Thank you so much. The field right now is just wide open. I've been so excited to see not only CAR T develop, but then trispecifics. And I read recently about the possibility of CAR T being manufactured inside the body. So it's crazy to think of what's coming. Okay, next question just says, what are the common psychosocial barriers you see with this diagnosis? Can you speak to what you see in clinic?
Yeah, I mean, I can even speak to my clinic this week. Ultimately, patients come in very nervous, very anxious. They don't know a lot of this stuff yet, right? What their actual risk is, what they have. They're just most of the time told they have a protein in the blood, and go see a hematologist, and then and it's quite mixed messaging sometimes, right? Should they be worried? Should they not be worried? So I think the first step is understanding the diagnosis, and in people that are, potentially have underlying smoldering myeloma, et cetera, I always encourage people to get the biopsies done, because that's how we truly know your diagnosis, and we can do some of these other tests on that and give you a much better sense of what you have. That doesn't mean everybody with MGUS needs a biopsy. I want to be clear about that, because there's some people that have such a minor abnormality. Actually, the biopsies in those patients many times don't even pick it up, because it's such a small abnormality. So generally speaking, it's first important to know what you have. But I will say there is this sort of burden of what's going to happen to me with each blood test, with each month or year that passes. And I think what I see is over time, patients adjust to it. In the beginning, it's very nerve-wracking, as it would be for anybody. But as they hopefully see their numbers kind of stay stable, and next thing you know, it's been a year, 2 years, few years, and then they start to say, okay, like maybe it's not as bad as I thought in a way, and I'm being monitored. The being monitored is a key part, because some people at that point stop being monitored. They stop worrying about it, right? So I think there's quite a spectrum there. One of my colleagues, Catherine Marinac, did a preference study which kind of looked at, of what do patients care about, and it was like a survey that they did, I think around 300 or so patients, and it was quite a variability, as you can imagine. Some were worried about, developing symptoms, some were worried about cost, some were worried about side effects from treatment, and So this is why you can't put everybody in the same bucket. But I will say there is definitely a psychological impact of this. And we're trying to study that a little bit better in some of these approaches that we're doing to see if that gets better, so there's quality of life questionnaires and things like that that are part of our studies. But it is no doubt something that majority of people do have in the back of their minds quite a bit.
Absolutely. Thank you so much. I think we've reached the end of our questions right now. We had one that I will get to a little bit offline. It's a little bit more personal. So I will get to that one a little bit later offline. Um, is there anything else you feel like patients need to know in this space right now? Anything you're excited about or any, other trials that you'd like to mention as well?
Yeah, I mean, as you just pointed out before with the tri-specific and there's so much going on. Things are moving faster than we can even keep up with that, I feel like, which is a great thing for patients. So I think we have to be strategic about, what we deploy in the patients that are pre-myeloma. But I would say in general, don't be afraid to, kind of reach out with your condition, with what you have, and don't be afraid to ask questions ultimately, right? Because this is a space that is, still quite unclear to some extent about what the right thing to do here is. And I don't think anybody has like a right answer either, right? It's like we're all kind of looking at the same data and making individualized decisions. So I would say, make sure you understand your options, understand your diagnosis. And then I always encourage participation in these clinical trials because, this is exactly how some patients really benefit from these therapies because this is the only way actually sometimes to get them, right? Because right now nothing is approved in this space.
Absolutely. So we have one more come in. We'll try and get to this real quick. So just asking about T cell exhaustion. It says, does T cell exhaustion occur only for long-term bispecifics or also for the shorter term treatments for precursors?
Yeah, great question. I don't think we have a clear answer to that, but basically what we have seen so far is the kind of more prolonged therapy and over time. So, some of these bispecific trials are looking at like just 6 months of therapy, which is amazing. So I really doubt that's going to trigger that kind of a phenotype. And it's also not forever either. I think there's probably some T cell exhaustion and then some recovery that happens over time. So we feel very excited about those types of therapies in these patients because of their real striking benefit. But then because it's not long term, perhaps not having any impact down the line, but we have to follow patients to know if that's truly true.
Absolutely. All right. Well, thank you again, Dr. Nadeem. It has been a pleasure speaking with you again and hearing from you again. We look forward to all of the updates that we'll be seeing in the coming conferences over the next couple months. So thank you for your time, and we will go ahead and close out today's session.
Thank you, Cynthia. Thank you, everyone, for attending. Take care.
All right. As a quick note, again, as you leave today's session, we'd appreciate you taking the 2 to 3 minutes to fill out a brief survey about your experience during today's event. The survey will appear as a pop-up once you close out of Zoom. This helps us tailor our efforts towards topics that are most meaningful to you. We have several upcoming events during the month of June that I'd like to highlight. On Friday, June 20th, we are hosting a virtual series with Cure Multiple Myeloma Corporation, where multiple myeloma patients can listen to one of the Karmanos Cancer Institute's phenomenal doctors to address their concerns. If you live in the Detroit area, you can register to attend in person, or if you don't live in Detroit, you can register through our website to view that event live. Then Tuesday, the 24th of June, our Black Myeloma Health group will hear from an inspiring panel of Black patients who have participated in clinical trial research. Again, this is such an important area, and we like to encourage everybody to look into them and see what possible benefit they can receive from clinical research. They will share their real life experiences, the challenges, the breakthroughs, and why representation in research matters. Then Wednesday, June 25th, we will have a cross disease event where Dr. Kelly McConnell will share simple, effective strategies to manage anxiety, reduce stress, and boost emotional resilience. This is for all blood cancers again, so if you know someone that might benefit, please encourage them to register. The months of June and July are packed with webinars and other events, so please check out our registration page through healthtree.org. I'll also send that in the follow-up email. I also wanted to highlight an exciting opportunity we're offering, which is our Connect to Cures program. These events are in person and are meant to bring resources and support and valuable connections directly into communities. If you're located in any of the cities shown on the slide, we'd love to have you join us and help spread the word to get this information out to people in your area. We've already hosted our first two events, and they've been a wonderful opportunity to meet new people, connect with them, and they introduce those resources into the community. The QR code on the screen will take you directly to more information, and registration details will also include it in the follow-up email. Again, I'd like to thank our sponsors, Adaptive, Pfizer, Johnson & Johnson, Amgen, and GSK. Lastly, if you've been inspired by today's webinar to look into joining a survey, we've got this survey up on the screen again. I will also include it in the follow-up email. Consider joining to help other patients down the road that are like you. And again, thanks for being part of our community. Your support really does mean so much to me, and I'm grateful to have you here. I've included my email address on the slide, so please don't hesitate to reach out. I'm always happy to help out.